Surprise. Oh.
After this, you want to show the surprise?
Yeah, that's right. Keep.
Testing 1, 2, 3. Yes.
Professor Anderson, do you have any hypothesis to explain why Wolff-Parkinson, why it is so rampant with Ebstein? Because anyway, the original fibrofatty annulus, which insulates, anyway remains where it was, right, in Ebstein. So that also is defective. And that, why is WPW so common with Ebstein?
I think that it all has to do with the formation of the valvar leaflets. We've spoken about this rotational displacement of the leaflets. In essence, the leaflets have failed to delaminate from the surface of the myocardial, from the endocardial surface of the right ventricular inlet. And I think that part of the separation, initially there's continuity all around the AV junction. And I think that part of the mechanism of separating by the fibrofatty junction, so-called annulus, I prefer to think of junction, separating that part is the displacement of the leaflet, which then impinges upon the groove tissue, which is there all the time. And I think if the valve does not properly delaminate, then there's nothing to make sure that that muscular continuity is disrupted. That is only a concept of mine. I don't think we've resolved fully the mechanism of separation of the atrial and ventricular muscle masses, and that's something else that it's in my intention to look further at if I get the time to be able to do that. It's a good question you ask. So I can only suggest that it has to do with the failure of delamination of the leaflets, and something to explore still further. So what Yash has asked me to do is to emphasize again for you the normal anatomy of the tricuspid valve and the normal anatomy of the right ventricle. And this is entirely appropriate, because if we don't understand normality, for sure we're not going to understand abnormality. So the point to make starting off is that the ventricular mass extends from the atrioventricular junction to the ventriculo-arterial junction. Now this is a particularly beautiful heart to show you the atrioventricular junction. So let's close in on this if we may. How close can we get? That's beautiful. Now that is spectacular, because you can see there, can you all see how? Running between the vestibular myocardium of the right atrium, the crest of the right ventricular parietal wall, we have adipose tissue. And it is that adipose tissue that is producing the insulation between the atrial and ventricular myocardium. There is the leaflet of the valve, and when I pick up the valve, you see that in fact the leaflet of the valve is turning back from the summit of the ventricular myocardium. And the separation between the two is produced by the fibroadipose tissue. There is no fibrous cord there. There it is. It's going all the way, and it's separating the vestibular myocardium from the myocardial muscle mass. Now that is also very beautiful, because it shows you another key feature of the right atrioventricular junction. There it is, the right coronary artery. And you all know that in 90% of the population, it is the right coronary artery that is dominant. And that is going to stay in that right atrioventricular junction in the setting of Ebstein's malformation. So now let me open the heart and show you the septal surface. And you see that from that atrioventricular junction, we have the normal hinge of the tricuspid valve. Here is the septal leaflet, and the septal leaflet is extending from the medial papillary muscle down to the inferior papillary muscle, and we have two heads here of the inferior papillary muscle. And probably I would divide the septal leaflet from the inferior leaflet at this point, and as you see, that is where the diaphragmatic surface turns away from the septum. So here is the hinge of the septal leaflet. We saw in the earlier session that I showed you the tendon of Todaro. At the apex there we have the central fibrous body. So there is the triangle of Koch. And that is going to stay where it is, irrespective of the extent of delamination of the septal leaflet of the tricuspid valve. Let's now turn our attention and let's look at the right ventricle. So now we describe the right ventricle in terms of its inlet component, its apical trabecular component, and its outlet component. And the essence of Ebstein's malformation is that the valvar leaflets are rotationally displaced. And they use as their fulcrum the membranous part of the ventricular septum. So in Ebstein's malformation, oftentimes we see a shelf at this point, and then we will see thinning of this inlet part of the right ventricle, and oftentimes this can be paper thin. On occasion, the myocardium can disappear from the inlet portion, and that has some affinity to Uhl's malformation, except that in Uhl's malformation, the entirety of the myocardium disappears. In Ebstein's malformation, it is this part of the right ventricle that becomes so-called atrialized because of the rotational displacement of the leaflets of the tricuspid valve. And that means that the so-called functional right ventricle then becomes the apical trabecular component and the outlet. And we can now see by what I've done, by turning this fold forward, how the orifice of the tricuspid valve will be moved so that it's looking into the outflow tract of the right ventricle. You can also very nicely now see the anterior papillary muscle of the tricuspid valve. When we trace from the anterior papillary muscle, you see that there is a structure crossing the cavity, which is the moderator band, and that is unifying with this structure, which is the septomarginal trabeculation, or the septal band. Arising from the septal band, we have this array of septoparietal trabeculations, and they extend all the way up to the subpulmonary infundibulum. This is not going to be distorted in the setting of Ebstein's malformation unless there is a ventricular septal defect. Because typically in Ebstein's malformation, when there is a ventricular septal defect, it is here at the site of the membranous septum, a perimembranous defect which will open to the functional right ventricle. In the normal situation, we see the supraventricular crest that is inserting between the two limbs of the septomarginal trabeculation, the anterosuperior limb, the caudal limb. So that is the normal heart. Let's now look at some malformed hearts. And this is quite beautiful. This is absolutely exquisite. I don't think you showed me this one before, had you? Had I seen this one before?
Yeah, you selected these.
I selected these. This is beautiful. I told you I'd forgotten this because this is absolutely perfect for showing you the rotational malformation of Ebstein's malformation. It's a relatively small heart. We can see the extent of the atrial myocardium because we see the pectinate muscles of the right atrium coming down to the vestibule. And very nicely there, you see the atrioventricular junction. And there you see the fibro-adipose tissue that will be insulating the vestibular myocardium from the ventricular myocardium. And when I fold back, the heart has been trying to delaminate. You see that almost there is tissue that is delaminated here. In fact, that is a bifoliate structure. We have hardly any myocardium left in this atrialized inlet component of the right ventricle. So look at that. The entire inferior margin of the right ventricle is paper thin, but when we look carefully there, we can see the level of the atrioventricular groove. There is the level of the atrioventricular junction. This is a venous structure. And in fact, in this heart, if there is an artery there, there might be an artery, but it is very tiny, and certainly it is not going to be dominant. So I'm not sure whether the presence of Ebstein's malformation means that the left coronary artery is going to be dominant. That is something that would be worth exploring. What we can see, however, is that if we trace that atrioventricular junction, we can see it going all the way up to the level of the central fibrous body. And there is the triangle of Koch. The triangle of Koch is where we expect it to be. So here is the atrioventricular junction, which is vertical. And what you can beautifully see in this heart is how the leaflets have rotated away using the area of the central fibrous body as their fulcrum. And this has produced the atrialization of the ventricular inlet component. And here we see that shelf, which I told you marked now the junction between the atrialized inlet and the apical trabecular component of the right ventricle. And what you can see, in fact, is that there are no longer any trabeculations on this thinned inlet portion. There are a few trabeculations there, but they are on the atrial surface of the dividing shelf. So we now have the tongue that I was telling you about between the inferior leaflet, which has failed to delaminate, and there is the anterosuperior leaflet, which is hinged from the atrioventricular junction. And here is the displaced septal leaflet, and that also has displaced away from the atrioventricular junction. So this inlet of the right ventricle, which remains right ventricular in terms of its electrical activity, because if all is proper, there will still be insulation here at the level of the atrioventricular junction. In fact, there is the right coronary artery. I can see it now. There is the right coronary artery. So it could well be that there is a dominant right coronary artery. But this, if there is any myocardium in here, it is still going to be activated as ventricular myocardium, yet hemodynamically, because of the location of the valvar orifice, this will be recording atrial pressure tracings. So if we turn the heart around and we look into the outlet of the right ventricle, there we see the functional right ventricle. And you see that here is the myocardial surface of the anterior papillary muscle, the moderator band. There are some hyphenated attachments underneath the moderator band, but essentially the valve is opening through this bifoliate orifice between the displaced septal leaflet of the valve, the displaced anterosuperior leaflet of the valve, and it's opening directly into the subpulmonary outlet. And there is all this abnormal muscular structure that is so-called tethering the abnormal valve to the walls of the right ventricle. Here there are still some septoparietal trabeculations, but all these abnormal muscle attachments are tethering the abnormal anterosuperior leaflet. And I'm sure when we hear about the surgical repair of this, we're now going to hear about the so-called cone procedure. What the surgeon is going to try to do is to take this valvar tissue, which you can see better from the inlet aspect, and you see here is a valvar orifice. So the surgeon will try to liberate this valvar tissue away from the walls of the ventricle and then rotate it back, create a cone out of this tissue mass, rotate it back and attach it at the ventricular arterial junction using that space there as the new valvar orifice and hopefully restoring ventricular function. So a lovely example of severe Ebstein's malformation. We now look at another one. And this time we look at how dilated is the right atrium. In fact, we expect dilation of the right atrium in the setting of Ebstein's malformation, because characteristically the atrioventricular valve is regurgitant. We can locate the location of the atrioventricular junction again by looking at the pectinate muscles. You see the pectinate muscles here become confluent with the vestibule, and here very nicely now we see the atrioventricular junction. This time there's been a bit of dilation also of the atrialized component of the ventricle. If we look at the valvar structure itself, we can see the triangle of Koch run up the there is the oval fossa, here is the apex of the triangle of Koch, and we can see there the level of the atrioventricular junction. So the triangle of Koch is where we expect it to be, but in this heart there has been gross dilation of the right atrioventricular junction. There is the anterosuperior leaflet, which is normally hinged from the atrioventricular junction, and here is the inferior leaflet coming back, which is rotated away with the septal leaflet. So if we turn the heart and we look at the outlet aspect, in fact we can't really do that. Oh, we can. There in fact is the outlet aspect. The heart hasn't been opened quite as nicely as the previous one, and in fact there is a cut here across the anterosuperior leaflet. So there now we see the keyhole. There is the keyhole between what is left of the anterosuperior leaflet and the septal leaflet, and that is looking directly into the subpulmonary outflow tract. And what we see here very nicely is these anomalous attachments through the muscle bars to the parietal wall of the right ventricle. And if the surgeon wishes to create a cone of this valvar tissue, the surgeon will have to divide all these anomalous muscle bundles, yet at the same time will have to retain the attachment through the tendinous cords to the apical bundles, because that is what is going to put the tension on the valvar leaflets when they open and close, when hopefully the surgeon has brought the cone of valvar tissue back so that its proximal attachments are at the atrioventricular junction rather than at the junction between the atrialized inlet and the functional right ventricle. So another one, huge dilation of the right atrium in this heart. So these are severe Ebstein's malformation. Nowadays we hope that patients with this lesion would reach the surgeon before they get to this stage. This is very much, this is even worse than what we saw in the heart of Joseph Prescher. This is showing us very nicely the location of the triangle of Koch. I'm picking up the eustachian valve here. We can see very nicely now the tendon of Todaro. You see there the tendon of Todaro springing into prominence. And there you see the level of the atrioventricular junction. And that is showing us very nicely that the triangle of Koch is still pointing upwards, and it's still in its anticipated position. But then we can see again how the hinge of the tricuspid valve has been rotated from the level of the atrioventricular junction. We can also see very nicely again that there is a connecting tongue between the inferior leaflet and the anterosuperior leaflet. There is the connecting tongue. In fact, it's very difficult to open these hearts properly without destroying the leaflet structure. And nowadays we will get a far better impression of what's going on by looking at computed tomography or magnetic resonance imaging. But what we can see here is that the inferior leaflet, in fact, is attached here at the atrioventricular junction. And it's only when we come here to the septal leaflet that we see the downward displacement. And a very nice study that was done by the Mayo Clinic by a namesake of mine, Kenneth Anderson, who moved from spending time with me to move to the Mayo Clinic and worked there with J.T. Lee, their pathologist. He looked at a series of Ebstein's malformations there, and he showed that the maximum displacement of the hinges of the leaflets is where the septal leaflet becomes continuous with the inferior leaflet. And this heart shows that very nicely, because here inferiorly the leaflet is hinged from the atrioventricular junction, but as we follow it round at the point where the inferior surface turns to enter the septum is the maximal displacement of the hinges of the leaflets. And there now again you see the rotational displacement, you see the tongue between now joining together the inferior leaflet, the anterosuperior leaflet, and once more, beautifully here, you see the thinning, the anatomic atrialization of the right ventricular inlet portion. Here is the apical shelf. Beyond there, we have the functional right ventricle. And in this heart, sadly, the functional right ventricle is also grossly dilated. Just look at that. This is unusual. This is very severe Ebstein's malformation. It is unusual to find this degree of thinning, not only of the atrialized inlet, but also the functional right ventricle. So you can imagine this right ventricle is not going to have been pumping at all. And there you see the grossly abnormal attachments of the anterosuperior leaflet. This is all the so-called tethering, but the essential opening of the valve is here, pointing upwards into the infundibulum, with the whole thing distorted somewhat in this heart by the extent of the huge dilation, not only of the atrialized inlet, but also the myocardialized outlet. Is this the final one? Yeah. So the final one this is exquisite. So Pradeep has saved the best for last. Again, it is a severe example of Ebstein's malformation. You do not want your patients getting to this stage. Showing you again the apex of the triangle of Koch pointing upwards. Apex of the triangle of Koch still where we expect it to be. Here is the atrioventricular junction between the vestibular myocardium and the atrial myocardium. This is where the septal leaflet should have been and turns down into the inferior leaflet. And then when we pick up the inferior leaflet, we see that it is hinged parietally at the atrioventricular junction. The maximal rotational displacement is at the union between the diaphragmatic surface and the septal surface of the right ventricle. And in this heart, we have a remnant of the septal leaflet of the tricuspid valve. And this is exactly what Dr. Viss was drawing in the heart of Joseph Prescher. So that structure is the remnant of the septal leaflet of the tricuspid valve that is filled with blood and essentially is a large blood cyst. And then the remainder of the valve is rather distorted in this heart, but you can see there we are in the functional part. In this heart also, the functional right ventricle is grossly thinned. You see the septoparietal trabeculations, and it is them that can produce abnormal tethering of the anterosuperior leaflet. So that, saving the best to last, showing you the remnant of the septal leaflet as in the heart of Joseph Prescher. Now, Pradeep says he has some surprises that he's brought for me that he wants me to discuss with you. So I don't know what is going on here. I've not seen these hearts before. So let's try and analyze it in a logical fashion. It seems to me that the apex of the heart is pointing to the left. If we try and get it back in attitudinally appropriate fashion, we can open here on the right side, and I can see that we're dealing here with a right atrium. We've got a morphologically right atrium because the pectinate muscles are moving all the way around the atrioventricular junction. As I look into this right atrium, I can see that there is a there isn't a superior, I thought that, oh yes, yes, there is a superior cable vein coming out of the roof of the right atrium. There is an inferior cable vein that's been cut across here that's looking into the oval fossa. There is a coronary sinus. So we have a nice right atrium. The right atrium is then running into the ventricular mass, and we see here that there is a valve that has septal attachments, telling me that that is a morphologically tricuspid valve. The ventricle here is coarsely trabeculated, telling me that that is a morphologically right ventricle. Now yesterday we discussed the cuts that Pradeep had been making, and we have one cut here that then branches to two outflow tracts. So this suggests to me that I'm going to be looking at double outlet right ventricle. I can't be sure of that, however, but there is the arterial trunk that is giving rise to the brachiocephalic vessels, so it's an aorta. Here is the arterial trunk that is branching into the right and left pulmonary arteries, the pulmonary trunk. And there is a subpulmonary infundibulum through which the pulmonary trunk is arising from the right ventricle. And there is an aortic outflow tract, this time not a completely muscular infundibulum, because there's fibrous continuity here between the anterosuperior leaflet of the tricuspid valve and the aortic valve. If we then look very carefully, there is the caudal attachment of the muscular outlet septum. There we see the muscular outlet septum. It has the aortic valvar leaflets on one side, it has the pulmonary valvar leaflets on the other side, and there is a small hole there that doesn't go anywhere. Is it supposed to go anywhere, Pradeep?
Oh, it's supposed to be intact.
So I don't want to push too hard, so I think that initially that was an interventricular communication. But what Pradeep is showing us here is double outlet right ventricle with intact ventricular septum. I think that is where I would have expected the interventricular communication to be initially, but it is closed during fetal life. And then the question then, is there a left ventricle? Pradeep tends to look for left ventricles. This is the right ventricle again, is it now?
Yeah.
So what we are looking at here is the left atrium, and in fact there is mitral atresia. So there's no communication between the left atrium and the ventricular mass. The only question is, we can see there's a coronary artery there, we can see that there is another coronary artery here, and if we made cuts here, perhaps there would be a tiny morphologically left ventricle, perhaps here, between this obtuse marginal artery and the inferior interventricular artery, because there
is no appendage.
There is no left atrial appendage. Pradeep is also correct there. So the left atrium is made only of the pulmonary venous component. I guess there are pulmonary veins, are there?
Yes.
So the pulmonary veins coming here, and there is no atrial appendage. So absence of the morphologically left atrial appendage. But I think that we can make the point that that is the left atrium, but it's not going anywhere. Sorry, I tell a lie there. You can see that there are in fact the pulmonary veins, and there is the cavity of the left atrium. That's beautiful. And so as we look down there, the pulmonary veins, this is the inferior cable vein. Here is the muscular wall of the left atrium. And you can see that the left atrium is somewhat hypertrophied because the only way out for the left atrium is the oval fossa, and the flap valve of the oval fossa, as we looked at the right side, looked as though it was restrictive. Certainly there's no wide open. There is the oval fossa. If we go across there, I can get my probe from right to left into the left atrium, but I fancy that the flap valve would have stopped it going in the other direction, which is why there's a degree of hypertrophy of the left atrium. So we've got mitral atresia, absence of the left atrioventricular connection, left atrial appendage, still, however, with usual atrial arrangement, even though in this instance I can't see the atrial appendage. The right atrium is connected to the morphologically right ventricle with double outlet, intact ventricular septum, and it's moot as yet as to whether there is a small left ventricle in this location, but I fancy if we make a cut along here, we'll find a slit-like left ventricle related to that component of the inferior ventricular wall. So that was a surprise. We have one more surprise heart that he wants me to show you. As I say, I don't know what we will find when we look inside these hearts. This is a smaller one still. I think that looks pretty much like a tubular appendage from the outside. That's on the left side. And in fact, very nicely, when I open this left-sided chamber, we see it has smooth walls. I'll open it and we'll look at it from behind. And we've got very nicely there a tubular opening of this left-sided atrial appendage, pectinate muscles confined within the appendage. So I think that that is indeed a morphologically left atrial appendage. And when I look at it now and I show it to you like that, you can see the hooked indentations along its length. So that is morphologically left atrial appendage. We'll turn around now and we'll look at the other side. And that is a morphologically right atrial appendage. Pectinate muscles running all the way around the atrioventricular junction. This time we have absence of the right atrioventricular connection. There is no connection from the floor of the right atrium crossing the right atrioventricular groove. And if we were to dissect this epicardial tissue plane, I would be able to lift the right atrial appendage all the way from the ventricular mass. So we have absence of the right atrioventricular connection. I'll now turn the heart back and I'll show you that the morphologically left atrium is passing through a morphologically mitral valve and is connecting with a dominant morphologically left ventricle. There are the papillary muscles of this morphologically mitral valve. There's an interesting finding there, because there you can see there is a hole in what we would expect to be the area of aortic or atrioventricular to arterial valvar continuity. I'm not quite sure where that's going to. We'll follow that, but let me look at the remainder of the heart first, because here there is an arterial trunk that is arising from the left ventricle, and I think that that was initially the aorta. I think there was a coronary artery arising from it just there. And then we have these additional holes that are going, this one at any rate is going into the morphologically right ventricle. You see that there is the muscular outlet septum. And I'll turn the heart back now and show you the morphologically right ventricle. So there is the morphologically right ventricle. It is an incomplete morphologically right ventricle because it lacks its inlet component. It lacks its inlet component because there is complete absence of the right atrioventricular connection. But still, it is a morphologically right ventricle because it has a coarsely trabeculated apical component and it has an outlet component. And the outlet component is supporting the leaflets of the pulmonary valve, 3 leaflets of the pulmonary valve above a completely muscular infundibulum. So there is the ventricular septal defect. This is tricuspid atresia, and there is the muscular ventricular septal defect. That was that hole. Where is this hole going to? We'll probe this hole, and I fancy that will be going to the apical component of the right ventricle. And there it is indeed. So you see that there is a second apical trabecular septal defect in this, leading into this incomplete right ventricle, and that is leading to the apical component of that incomplete ventricle. And what is interesting now, apropos our discussions of the conduction system, is that the conducting bundle will be running through this tissue bundle that separates those two parts of the atrioventricular conduction, of the ventricular septal defect, because there is the area of the membranous septum, and the conduction bundle will be coming down here. We have this additional space there, and I think that might well be an aneurysm of leading into the atrioventricular groove. Did you probe that, Pradeep?
It is this bulge. It's going
So,
into that
that's
bulge.
beautiful. So, as you see, in fact, that hole points back into the area of fibrous continuity, what should be fibrous continuity between the mitral valve and the aortic valve, and it is this bulge that is coming back above the mitral valve. So, tricuspid atresia with two ventricular septal defects, and this aneurysm of the area of fibrous continuity, in fact, not between the leaflets of the mitral valve and the aortic valve.
So is it like intervalvular fibrosis?
Intervalvular fibrosa, an aneurysm of the intervalvular fibrosa. Absolutely. And also, one other interesting point to make, I think that there is fibroelastosis on the surface of the dominant left ventricle, but this is a small heart. Okay? So, mystery hearts easily solved by simply describing what you see.
Yeah.